but please know that we will be taping this and be posting it on our website. We invite you to be interactive. Emily is really psyched to talk about syringe exchange and harm reduction. This is a concept that is kind of new to a lot of people around here. So ask us your questions, ask us your concerns. One of our core values at the Catskills Addiction Coalition is asking questions that might make us uncomfortable sometimes, and engaging with each other in the spirit of inquiry and learning, and coming together to help reduce death and harm in our community. Mike, did I say who I was? No, I'm Julia Reichel. I'm the co-chair of the Catskills Addiction Coalition. And this afternoon, we are talking with Emily England, who is the director of programs at the harm, and she's talking about harm reduction. You're the director of programs and harm reduction? Is that it?
Yes,
at the Southern Tier.
Difficult
yeah,
title.
Tell me. Okay, say your title. You'll do it more fluently than I will.
Director of Programs Harm Reduction. See, I can't even do it.
Got it. Okay, cool. At the Southern Tier AIDS program out of Binghamton. So this is a syringe exchange, to be clear. And they have been operating for a long time, and she'll tell you all about it. Before we get started, I will tell you that we are evaluating this whole summit and every session, and we want to hear your feedback. I'm going to drop some feedback forms into the chat box. Feel free to put your own questions in the chat box. We love questions. I will either interrupt or notify Emily if you have one. Again, you can also feel free to jump in. You can raise your hand. You can just turn on your sound, and I'll mute you if it's not going to work. But we really do invite you to jump in. It's better that way because we all stay more engaged. What else? John Barry, who's the executive director of STAP, is going to talk a little bit about a whole conference that's on harm reduction that's coming up pretty soon. I'll have him talk. Yeah, maybe after I close this up. Let's see what else. Keep your mic muted when you're not talking. That'd be great. And I think that's basically all the housekeeping. John, would you talk a little bit about that harm reduction conference? Just get us started with it. We're still having some folks come in, so I'd like to hear about it. John, you're on mute.
Yeah, that's what I said, but no one heard me because I was muted. There's a new statewide organization that's been formed. We have a number of members from upstate New York and also New York City. It's called the New York State Harm Reduction Association. And we're going to be holding a virtual conference January 27th, 28th, and February 3rd and 4th. There's going to be some great content from folks who are college professors. We have a very well-known clinician, Andrew Tatarski, who we affectionately refer to as the father of harm reduction treatment. We have a whole bunch of panels on, people doing peer work in substance use and harm reduction. It's over the space of 4 days, but they're only half days, so you can get some other work done the rest of that particular day. And the price point is pretty cheap. If you're a member of the association, we would certainly invite people to join. It's only $100 for the conference. If you don't want to join, that's fine too. It's $150. If you're one of those people like myself who has a lot of people in your organization and you want to send like 25 of them, you can do that for $500. It's a bargain.
Step right up, says the man. Without further ado, I'm going to ask Emily to take it away. I'm really eager to hear sort of the rundown and history of syringe exchanges.
Great, thank you. All right, so I'll start by doing a little bit of an introduction. I'm going to go over a little bit about STAP, who we are, and then we'll dive right into syringe exchange and all it has to offer. I was telling Julia before we started that I could talk about syringe exchange all day. I love it. And I tried to really condense this PowerPoint. So if there's something that you are really interested in or have a specific question, feel free to reach out to me afterwards and we can talk about syringe exchange all day. So yeah, my name is Emily England. I'm the Director of Programs Harm Reduction at the Southern Tier AIDS program. I've been with the agency for 8 years now and have been in many different roles. My first role was actually working part-time in the syringe exchange, and then I never left. So I'm really excited to talk to you today about syringe exchange and what our programs look like. Sorry, I'm trying to make my slides work. There we go. Okay. All right, so a little bit about the Southern Tier AIDS program. Some of you might be very familiar with us. Some of you might have heard of us, but we are an organization that operates through an 8-county region in the Southern Tier of New York. Broome, Shenango, Chemung, Cortland, Delaware, Otsego, Tioga, and Tompkins. It's only taken me 8 years to be able to do that without looking, but, and we were established in 1984 as an AIDS service organization serving people who were affected by HIV and AIDS. And since then we have expanded greatly to serve many, many different populations, focusing on the prevention side of things, people with chronic illnesses, lots of different things throughout our organization. Specifically today, I'm here to talk about our 3 fixed syringe exchange sites. We have 3 syringe exchanges. We have one in Broome County, Tompkins County, and Shenango County. And there's lots of different aspects of that. So we'll get into all those different things. And then I'm also going to touch upon a few of our other programs that kind of fall under the umbrella of our harm reduction and prevention side of things. One of those being our drug user health hub. So we were one of the first 4 drug user health hubs in the state. And we are able to offer low threshold medical care for people who use drugs. So that's something we'll also talk about as well. That goes hand in hand with our syringe exchange. You can't really talk about syringe exchange without talking about harm reduction. My wonderful supervisor, Michelle McElroy, will be doing a much longer presentation on harm reduction tomorrow. So if anybody can attend that, I really encourage you to do so because she is a great person to hear present and talk about harm reduction in depth. But basically what harm reduction is it understands that substance use is part of our world, and it's our job to do what we can to help minimize the harmful effects that it can have. And it's a continuum of behaviors, right? So it's a spectrum of behaviors. So there can be heavy drug use all the way into complete abstinence. And then people kind of fall somewhere within that spectrum, right? So some folks might be at the same place for a long period of time, or they might change throughout that spectrum. And then harm reduction also realizes that there's other things that affect people's vulnerability to drug-related harm. So things like poverty, class, racism, sex-based discrimination, all those different things that we're trying to address to help people stay alive and healthy. So a little bit about syringe exchange in New York State. Syringe exchange programs began as a public health initiative in around 1992 as a response to really high rates of HIV among people who are injecting drugs. Currently, there's around 30 programs in New York State. Most of those are in the downstate New York City, Long Island area, but there are a few of us in upstate New York. As we all know, upstate New York is quite rural, so 9 of us is not enough. There needs to be many more, but we do what we can. And all of these programs are regulated and supplied by the New York State Department of Health AIDS Institute. So that is who gives us all our supplies and make sure we have what we need and the resources we need so that we can serve all the folks we serve. And that's a lot of people. Any questions so far? I don't want to miss anything in the chat. I know it's only been a couple minutes, but okay.
You're good.
I have a question.
Yes.
Why did New York State think that syringe exchange was a good idea, and were they right?
They were absolutely right. In a couple of slides, I have that after the introduction of syringe exchange programs back in 1992, the rates of new HIV infections among people who are injecting drugs fell well below, it decreased by over 80%. So it really did what it needed to do and allowed people to have the resources and the tools that they needed to prevent new infections of HIV and connect people to the care that they needed. I hope I answered your question. And okay, so moving on to, I just wanted to give a little plug about our location. So like I said, we have 3 fixed sites. Our first location opened in 2002 in Ithaca. It's right on West State Street. This is our second location in Ithaca. It's the big purple building, and we have an entrance around back that's private for folks. Our second location opened in around 2008, and that's on Main Street in Johnson City. That's our Broome County location. Again, it has its own separate entrance for folks, keep more discreet and private for them. And then our most recent location is in Norwich, so our Shenango County Prevention Point. Right now, this location is only open 1 day a week. We're open on Tuesdays from 10:30 to 3. Right now, we don't have the staff capacity to be open much more than that, although we try to get up there as much as we can when folks need us. But right now, we're there 1 day a week. Okay, so a little bit about our syringe exchange services and our goals. Really, the main goal of the syringe exchange program is to provide people with the safe injection equipment that they need. So as we know, sharing of injection equipment and supplies increases people's chance to transmit bloodborne illnesses like HIV and hepatitis C and other things like infections, abscesses, things like that. So we provide safer injection supplies and education to folks so that they can continue what they're going to do as safely as possible. So giving people the actual syringes themselves and all of the other supplies that they need to do what they're going to do as safely as possible. Another goal is to prevent new cases of HIV and hepatitis C. So through education, counseling, and testing, like I spoke about a little bit earlier, really trying to decrease those rates of HIV and hepatitis C. So when folks come in, we're talking about transmission, risk reduction, letting them know about how long Hep C can live outside the body, HIV, different things like that, really trying to educate folks so that they're aware and might know their own perceived risk. And then talk about, the testing that's available. Do they know their status? Do they want to come in and get tested? What that availability looks like for them. We are proper use sharps disposal for clients in the community. So we are a syringe exchange program. So in order for folks to acquire new or more syringes, we ask that they bring them back to us so that we can dispose of them properly. So when folks bring their used syringes back to us, we're able to take those, dispose of them properly, and give them new syringes so that they are, not disposing of them in a different way. Also for community members, if anybody sees a syringe maybe on the sidewalk or in a playground or in a public restroom, they can call one of our staff members and we can go out and pick that up as safely as possible so no one else has to attempt to do that. We are an opioid overdose prevention program, so we are able to provide naloxone training and kits to provide overdose education. So allowing people to obtain a naloxone kit is one of our most important goals. Every time somebody visits our syringe exchange, we ask them, do you have a Narcan kit? Do you need a new Narcan kit? And we're talking to them about the risks and risk reduction around overdose prevention. And we'll get into some of the details about that later. We provide safer sex supplies, so right along with our harm reduction philosophy, and we're a point of entry to other social services, including substance use treatment. So when folks come in, I know we've all heard the saying, meet folks where they're at. That kind of is like the second kind of saying that goes right along with harm reduction, but that's really what we do and encourage all of our staff to do. Is when folks come into the syringe exchange, we want to have a discussion with them. We want to talk about, are their basic needs being met? Do they have food? Do they have shelter? Do they have health insurance? Have they seen their doctor anytime soon? Are they feeling safe? What that looks like for them. And maybe that day that they come in, they don't want to talk about it, but maybe next week when they come in, they say, oh yeah, I need help, recertifying my Medicaid or something like that. And we have navigators right in-house who can sit down with folks and help them right away, and they have access to those services. So we try to be, a point of entry to those other things. Also with substance use treatment, if somebody comes in and says, I want to talk about detox, I want to talk about Suboxone, we have folks that can help them do that. That's a difficult process to navigate on your own. Insurance dictates a lot, and we want to make sure that that process is easy for folks if they're ready. So we have folks that can help them through that process too. So a little bit about how syringe exchange works. When our participants come to our syringe exchange and enroll in our program, they're given a syringe exchange ID card. So our program is anonymous, so we don't take any names or any identifying information. The most identifying information we take is their date of birth and their zip code. Other than that, we don't know anything. Some folks like to share their name with us, some folks don't. It's totally up to them and what they feel comfortable with. But when they enroll in our program, we use their initials and their birth date to generate an ID code that goes on a card for them. When they have that card on them, they're covered from any charges for carrying syringes on them. So I listed the penal codes for the two things that our syringe exchange cards cover. So if folks are in possession of syringes that they acquired from a syringe exchange program or an ESAP, which is an extended syringe access program, that would be something like a Walmart, a Walgreens, a CVS, other pharmacies where they can purchase syringes. They are allowed to have those and they are not able to be charged. The same thing with the residue that's left in a syringe. So in order for folks to bring their syringes back to us and exchange them, they need to be able to bring them back to us, right? With that residue in them. So our card covers that for them. So it's not going to cover like a loaded barrel of a syringe or any other paraphernalia, but it does cover a syringe that might have a small amount of residue on it. Our folks, when they come to our syringe exchange, they're provided, like the first day they come, if they have no syringes on them, they're provided with 20 syringes to start. That's 2 packs of syringes, so 10 in a pack, and whatever other harm reduction supplies they need. You know, we're not super strict on this because we know that sometimes if it's a Friday and people go through 30 syringes in a weekend, we want to make sure they have enough to get by till the next time they can come and see us. So we are, you know, we do definitely work with folks so that they have enough supplies to get by. And our exchange procedure is technically 1 for 1 plus 20. So if they bring me their 20 used syringes back, I can give them 40 clean ones. If they bring me 40 used back, I can give them 60 new ones. It works like that. Any questions on how syringe exchange works? Nope. Okay. And here's a list of some of the supplies that we give out. This isn't all of it, but these are some of the main things. So we give out both intramuscular and that should say IV. I'm sorry, I'm used to with naloxone doing nasal spray, but IM and IV syringes for folks. It's whatever they feel comfortable with, whatever size they need. Really depends on what substance they're using and, you know, maybe what they prefer in terms of length and width of a syringe. And then we give out sterile water, alcohol pads, tins for mixing their substance, a cotton filter. One of the newest things that we've been able to give out in the past year or two are fentanyl testing strips. So as many of us know, lots of fentanyl has been showing up in heroin and lots of other substances. So we're able to give folks these tools so that they can test their substance so they know how potent it is prior to using that. And those are really popular for folks, and we're really, really fortunate that we're able to give those out as another harm reduction measure. We give out sharps containers so folks can bring their syringes back to us in a safe manner, and hygiene products, because we know that, you know, health starts, you know, not just with syringes. We want to make sure people have hygiene products so that they can also take care of themselves if that's what they choose. This next slide is just going to go over some of the most common things that we hear when we talk about syringe exchange or when it's introduced. Something we hear a lot is that bringing a syringe exchange to a community would increase drug use or increase crime. That has actually been proven to not be the case. Programs or areas with syringe exchange actually have decreased drug use in their area because they have more access to those services that they need. Same thing with crime. You know, our folks are super, super respectful of our space. They kind of uphold the rules to everyone else, probably more than our staff does. They're really protective of our space and want to make sure that, you know, we can operate and stay open. So we, you know, typically have never had any issues with that. And then we also hear that there could be an increased number of syringes improperly disposed of in the community. And like we discussed a few slides back, you know, we're able to dispose of syringes in a safe manner. And in order for folks to get new syringes, they need to bring their used ones back to us. So it's really that incentive for folks to bring them back, dispose of them properly, and not just throw them in the garbage or throw them, you know, wherever is convenient for them. It really is that incentive for them to bring them back to us. And then cost is also just the way to drive it home, right? When you talk about money with folks, as you can see, what we have listed there, treating 1 case of HIV or treating 1 case of hepatitis C, and that's without a liver transplant, is around, is quite expensive. And then listed at the bottom are 3 syringe exchange sites. We have a mobile unit. So we have a large white Sprinter van that can go out and do syringe exchange in the community. in a peer program, which we'll talk about in a few slides, we operate, as you can tell, on less than just a few cases of HIV and Hep C combined. So if we're able to prevent new cases from happening, that's great, because then we aren't, having folks' costs go up like that. I know I see the chat going off, so I'm just going to check and see if maybe there's some questions. Yes, and John just added into the chat, which is great, that treating a case of endocarditis, which is an infection that surrounds the heart, which is common in individuals who inject substances, is around 50,000 plus per case. So we do a lot of education around infection prevention and reducing those cases. And then some impact of the syringe exchange program. So syringe exchange participants are 5 times more likely to enter and complete treatment. So as we talked about, we have navigators right on site. We're able to sit down with folks, talk about their options, talk about their insurance. We can transport them to treatment, whatever resources they need or what we can help them do, we're there to do it. So that's awesome for folks. And since I already mentioned that since syringe exchange started back in 1992, HIV infections among people who inject drugs have decreased by over 80%. So that's also wonderful. And it significantly reduces the amount of improperly disposed syringes in communities. So again, like we said, a syringe exchange, in order to get more, folks need to bring them back. So there's that incentive for them to dispose of them properly. And the point that we say a lot, and that we drive home, and that I think is our answer a lot of the time when people ask us, why do you do what you do? Why do you give people the tools to just continue to use drugs or just to continue to do what they're going to do? My answer is always, I want to keep people alive and healthy long enough to make different decisions about their health, whatever that is for them. Whether that's they stop using, whether that's they reduce their use, whether that's they talk about Hep C treatment, whatever that is for them, they can't make those decisions if they have overdosed or if they are in the hospital with an infection. So it is our job to keep them alive and healthy at the end of the day. So the next couple of slides, I'm going to get into some of the other programs under our syringe exchange and harm reduction umbrella. So like I talked about in the beginning, we do HIV, STI, and Hep C testing right on site. So we provide rapid HIV, Hep C, and syphilis testing. Those tests all take total 20 minutes. So we really encourage folks that it doesn't take super long. They can know their status really quickly, and then we can link them to any other services that they need, should that be follow-up testing, treatment, whatever that looks like for them. We also do urine collection for chlamydia and gonorrhea. We don't have a lab on site, so we have to mail that off, but it's also a great resource for people. And we talk a lot about sexual risk reduction, education, and resources. Sometimes we have individuals who come in that disclose that they're engaging in transactional sex, and we can have discussions about safer sex practices for them and what that looks like for them. We have a great PrEP program manager that works at both of our syringe exchange offices. His name is Liam, and he links people to PrEP, or pre-exposure prophylaxis for folks, which is a daily medication that can reduce the risk of transmission of HIV when taken every day. So that's something that we talk to lots of folks about, especially those who have sexual risk and those who are injecting substances. We also have a newer program, which is our Hep C treatment navigation. So there is a treatment for hepatitis C, which is wonderful, but that process can be pretty daunting. And we have a navigator who's wonderful and works with folks of our syringe exchange and our health hub to navigate them through the Hep C treatment process. So walking them through their first test, to their blood draw, to obtaining their medication, to their last final blood draw. She walks them through that whole process. I talked about this a little bit in the beginning, but we are an opioid overdose prevention program. We've been that for many, many years, I think even before I started, so it might be 10 years now. But we are able to provide a skill building program, which is designed to prevent fatal opiate drug overdoses. So this is offered to people who inject drugs, friends, family member, community members. Really, we try to focus on people who are at high risk, right? So not just people that want a kit or have heard about it and really want a kit. Totally, they can obtain a kit on their own probably at a pharmacy. But for us, we really want to get these kits in the hands of people that are more high risk. So people who are injecting substances themselves or have a friend or a family member close to them that are at higher risk for an overdose. So this training takes about 20 minutes total, sometimes a little bit longer when we're doing a community training. But after the training, the individual is provided with an naloxone kit, which is 2 doses of Narcan. It also is a prescription to be able to carry and give out this life-saving medication. So we're really fortunate that we're able to do that and that we are able to get as much naloxone as we do. For those who aren't familiar with naloxone, naloxone works by temporarily blocking those opiate receptors in the brain. So when somebody uses too much of an opiate, those opiate receptors are blocked. And those are the same receptors that gives the body the ability to breathe on its own. So when naloxone is injected into the body or sprayed up the nose, it goes in and kind of puts a blocker up on those receptors and allows the body to breathe on its own again. It is short acting, so we do encourage people to go seek medical care after the overdose, just in case they were to overdose again. But it's a wonderful life-saving drug, and we encourage everybody who feels that they could benefit from having a kit to contacting us and getting one. In 2020, there were about 284 reported overdoses to us. So when we give out these kits each day, we encourage folks that if they use them, that they report that back to us so that we can report that back to the state. And this number is quite high, as you can see, and that's just the reported ones. As we know, there's probably many more that weren't reported back to us, but these were just the ones reported to our syringe exchange staff. And we gave out around 1,600 new kits last year in 2020. With COVID, we were really upping how many people needed Narcan kits, doubling kits, things like that, because we knew, one of our most talked about harm reduction techniques is not using alone. But when everyone is encouraging you not to gather in groups and to be alone, that increases the risk of overdose, right? So we were encouraging people and really talking about different measures that they could take to stay safe and reduce the risk of overdose during that time. One of our other programs, and something that is really incredible that we have, is our peer-delivered syringe exchange program. So currently our agency has 6 deputized syringe exchange peers that serve within our 8-county region. So these are people who are familiar with the injection community, and they were, said, hey, I can serve folks. I have the ability to reach a group of folks maybe in a rural area or a group of people that they know that aren't coming to our office. And what we do is we train them, and then they're able to go and do syringe exchange outside of our office hours or in the community, whatever works for them. Some people do it at night, some people do it early in the morning, whatever works for them. It's really great so that we can reach people who might have transportation barriers to get to us or might not feel comfortable coming to the syringe exchange. Our peers are just a wonderful asset to our program. Our peers check in with our syringe exchange staff once a week. They hand in paperwork, they get new supplies, they hand in their use supplies, and they just chat with staff about any new, events or any information. And then they're also able to provide harm reduction information to those participants. So they're not able to do maybe as much of the navigation piece that our staff is, but they're able to link folks up with staff. Like they might come in and say, I talked to somebody who needs a primary care provider or is interested in Suboxone, and then we're able to link up with them, which is great because maybe they wouldn't have come in or known about that service without interacting with one of our peers. And our drug user health hub. So again, this is one of our newer programs. It's a program we're really proud of and we really love. It was established in late 2016. So it feels like just yesterday, but it was a while ago. And it's kind of our baby. We're one of the first 4 initial drug user health hubs funded through New York State Department of Health, Office of Drug User Health. And our goal was to increase medical care to people who inject drugs by integrating low threshold medical services into our harm reduction programming. So what we were noticing is that individuals were coming into our syringe exchange and they had infections or they had other medical concerns. And when we, encouraged them to go to the ER, go to the walk-in, they refused because of things like stigma or fear of repercussions, or they might have been treated poorly in the past. And what we decided to do is just bring the medical care to them. So we work with the subcontracted providers at Reach Medical, and they are right down the street from us. It's very convenient, and they're available to all of our folks to be able to assess their wounds, talk about any medical concerns that they have. And then off of that, we also started our Suboxone program. So we started with a very small number of slots. I think it was it 25 we started with, John? Around there, 25, and we filled that in about a week and a half. And then we were able to expand as Dr. Waldman and some other providers came on and expanded their availability to prescribe. So that has been a great, successful program for us. So we're able to offer low threshold Suboxone to folks through our program. So we don't require what maybe a typical treatment facility might, right? We don't require people to present daily or even present weekly. We don't require people to urine screen, lots of different things that we don't require because we want to make sure that there are as minimal barriers as possible so people can just stay alive and healthy and get on with their lives and not feel trapped by all these hoops that maybe traditional treatment makes them jump through, right? So that's been a really great program for us. And not to end on a downer note, but I did want to talk a little bit about what COVID, the impact that COVID had on our syringe exchange program. I could brag about our staff all day in the syringe exchange. They really kept our program afloat the past year. When COVID hit, there was never a question of, are we going to close? Are we going to stop serving folks? They were there every day, ready to serve folks in whatever capacity that looked like. But as it affected everybody else's lives, it really severely affected our program. So what we did initially is we stopped serving folks inside the building. And what we did is we delivered syringe exchange supplies to them, either at their home or an agreed upon location that felt safe for them. They also could pick up their deliveries right outside our back door, so that there was minimal contact and folks could still get their needed life-saving supplies that they needed every week, because we knew just because there's a pandemic, people still need syringes, they still need their supplies, and we still needed to be there for them. So that's what we did. What else we did is our prep program manager is also just a carpenter on the side apparently, and was able to build us this structure that you see right here, which is a piece of plexiglass that rolls up to the door so that we could serve people easily through the bottom opens up and we can hand people things out of the bottom, which was wonderful during the warm summer months. It's been a little bit challenging now that it's cold and we live in beautiful upstate New York, but we wear lots of layers and have lots of space heaters, but we make it work. And in our Ithaca office, they decided to use our mobile unit. So the window of the side of the mobile unit opens and they are serving people out of the van. So that works for them and it works for our participants and it keeps everybody as safe as possible. Unfortunately, with COVID, we did run into a syringe and supply shortage because of what was going on nationally and globally. We ran into a syringe and supply shortage, which really affected our program. We had folks that come in and get 300, 400 syringes at a time because they come in once a month or every 2 weeks, or that's what works for them. And we really had to decrease our cap. So right now we're only able to give people 200 syringes at a time. And depending on how much we get from our delivery every month, that sometimes changes. So we're still able to give people supplies, which is wonderful, but we've really had to ration what we have so that we can make it last every month. I touched on this already, but we also increased our overdose prevention training and strategies with the increase in isolation for folks. There was a really great resource that maybe some people are familiar with that was a telephone number that people could call into while they used, so that if they didn't get a response from the person on the line, they knew to send EMS and emergency vehicles so that they could address the overdose. So we talked a lot about that. We talked about how to reduce people's risk when they were more isolated. And then we did a lot of COVID education too. So we give out a ton of masks. We talk about the importance of wearing masks. We talk about washing hands, things like that. We give out a lot of soap, a lot of hand sanitizer, just doing whatever we can to keep people as safe as possible. And we've done a pretty good job. We haven't, knock on wood, had to close or stop serving folks yet, which is great. And we're really fortunate for that. And that's the end of my presentation. Does anybody have any questions? Or again, I have my contact information here. So if you want to reach out to me specifically about something else, I'm happy to go into more detail about a specific topic.
I would like to ask you about how and whether harm reduction enables drug use.
Wow, that's a great question. My short answer to that is no. But my longer answer to that is, you know, we always use the example with harm reduction of, you know, driving in a car, right? When you drive in a car, you have to do that. Most people have to do that every day, right? Or people who live in a place where a car is necessary to get from place to place. But there's things in that car, right? A speed limit, a stop sign, a seatbelt, an airbag, all those things, so that if an accident happens, right, you are protected. So if you think about that in terms of drug use, right? So people are going to use substances, but they have things like new syringes, Narcan kits, safer injection information, all those things. If an accident happens or an overdose happens or an infection happens, they have the resources to remain as safe as possible. You know, it's almost like when we talk about when, you know, you do sex education in schools and they say, if you talk about condoms or you talk about things, kids are going to have sex. Well, no, they're going to do it anyway. And that's how you look at drug use, right? Like illicit drugs are just part of our lives and people are going to use them no matter what. So in order to have the resources and the supplies available for people to do that as safely as possible, it actually reduces the amount of drug use happening, right? Because they have the access to the services and the resources that they need. I hope that answered your question. That was kind of
Julia, I would also say that I think that there's an urge that people have to pivot to this place, and I understand that urge to say, you know, we should just put all these folks in treatment, and I don't think that's a bad urge by any stretch of the imagination, but I think folks need to understand that number one, there's not enough treatment capacity in our state to handle everybody that wants to go, and our syringe exchange participants, because at one point we asked them, we said, how many of you have been to treatment? And can you guess what percentage of our syringe exchange program participants have already been to treatment? Sometimes multiple times, by the way.
100%.
We're at about 80.
80, yeah.
So they have been to treatment. It hasn't worked. And there's a whole nother discussion that we need to have there about, you know, what constitutes treatment and what we consider offering people the full spectrum of treatment and all those sorts of things. But that's probably another presentation.
We do have a couple questions. Jane, go ahead.
So I work with the Shenango County Drug Court, and I'm curious because I'm trying to figure, how do you get drug courts to be more receptive to the harm reduction model? Because they're, I mean, of course, it's by nature, it's essentially a punitive system. So, because I've been thinking about this, well, all day, because today was drug court day. But how do you find that balance of, because yes, drug court has a particular goal in mind, as does harm reduction. So how do we figure out how to marry the two so that actually we're really achieving something positive?
When our participants ask me about drug court, I tell them not to go. And the reason the reason I do that is because they ask, the bar is very, very high for people. And in order to qualify for drug court, my understanding in most municipalities is that you have to actually plead guilty to, you know, all the charges that have been leveled against you, and you lose your ability to plead those charges down. So I, on a pretty routine basis, encourage people not to be involved in drug court. But having said that, we have had some good working relationships with local drug courts. And I think the key is, the key for us anyway, has been to bring the judges and perhaps some of the staff into our syringe exchange programs and sit down and talk to them and explain that we're all trying to get to the same place in a different route.
Mm-hmm. Yeah, there's so much work there. And you know, and
we'd love to host.
Yeah, I mean, it would, and I mean, Shenango has a really, I think we have a really good team as far as being understanding that you can't just order it and so it shall be. That people are just going to be sober, and they're going to be sober, and it's going to be abstinence only. It's, you know, the reality checks are pretty much daily on that. So
Yeah,
I can wonder.
I think the Shenango County community is wonderful, actually, to tell you the truth. I'm very impressed with, and have a long-time relationship with, you know, your commissioner of mental health. And we used to have a staff member that used to sit down in the drug court meetings, and you have a fabulous public health director. I mean, it's a very close-knit community. And I think my experience there has been that people are approaching people that have substance use problems with a lot of compassion and love, frankly.
Yeah. I wish I could say the same for Delaware, but
In there, we're gonna work on it.
yeah, I was so close, and then the shutdown happened, and I can't seem to get my foot back in the door. But whatever.
I mean, it sort of takes, you know, it takes a sliver. Folks have been talking about syringe exchange in Delaware County for a long time, and the topic has sort of gone underground. So even just having a session about it is useful, and we appreciate it. Casey, you said you had a question. You want to unmute yourself and show yourself?
Oh, I'm not really show worthy, but I'll unmute.
Okay.
Well, I was just wondering about how widespread this is available throughout the nation. Is this unique to New York, the syringe exchange? And also, how widely available is it throughout New York?
So it's not unique to New York. There are many other states, I don't have an exact number of, who do have some form of syringe exchange or a syringe access program. Many do not, and many have what I will call underground syringe exchange, right? Where syringe exchange really started, or they have folks that do syringe exchange out of the trunk of their car or where they can do it, which is wonderful that they're able to do that. It's not unique to New York. In New York, there are not enough of us or not enough syringe exchange programs. We have a very difficult time reaching a lot of the rural areas or rural pockets of New York, where we are lucky that we work pretty closely with the other syringe exchange programs in upstate New York, Albany, Buffalo, you know, Hudson Valley, places like that, that we're able to connect with them and, you know, bounce ideas off each other and reach areas that, you know, we aren't able to reach as an organization. But it's definitely not enough. There's lots of programs in the city, right? You can go down and, you know, there's a syringe exchange on every block, not really, but there's a lot of them, which is like our dream. But yeah, upstate is, although we're lucky for what we have, we're still struggling with accessing all the folks that actually need us.
Okay, thank you.
Does anybody have questions about harm reduction, just how it sort of rubber hits the road works, in practice? Because I hadn't even heard of the term until a year and a half ago or so. And my initial reaction was like, what does it even mean? Like, what is it? I know we've talked about this a lot, but like the term kind of, sometimes I say like, oh, don't you want to reduce the harm of X? And that seems to make more sense sometimes, right? So I'm just wondering if folks have questions about that. I also wonder if people have like lessons they've learned from engaging about this, just with more sort of absolutist, prohibitionist styles of thinking. Like, what are best practices when we're introducing these principles and strategies in our communities?
One of the things that I like to tell people, Julia, about harm reduction is that I didn't know I was doing harm reduction, but when I was in graduate school back in the mid-90s, I'm old, I was working in a methadone clinic, and what it looked like in that setting was we did urine screening of folks because we were legally mandated to. So, but when we did it, it wasn't a reason to reduce somebody's medication. In fact, it was often a reason to perhaps raise their dose. And it was an opportunity for a discussion with the patient to be able to say, okay, we did your urine screen and, we came up with, this particular substance in there, so can we sit down and have a talk? And, what's that about? Why, if you're on this dose of methadone, are you still using heroin? Do we need to up your methadone dose? Why, why is cocaine showing up in your urine? What was going on there? And when we could, be quiet long enough to let the patient talk and explain what was going on, we often found a way, out of that problem, to the other side of it. The other thing I would say about that particular setting was that people could come in and get methadone and leave. That's all they had to do. But if they wanted to, there were a whole range of other things that they could take advantage of. There were NA meetings on site. There was a psychiatrist whose specialization was in addictions that they could see. They could see a counselor weekly if they wanted to. So there's all these other auxiliary services that were available to them, but none of those were they compelled to take part in.
I mean, central to this idea is autonomy, right? We're recognizing that people make their own choices, even if they're bad choices that hurt them.
Which we freely offer to
And that's real hard.
other chronic illnesses, by the way.
Yeah. Well, yeah, and also just people. I mean, we don't prevent people from climbing in a tree too high and like walking on a branch too far out, this is the thing that sort of stymies me about the cultural problem with this, because I think actually harm reduction's emphasis on autonomy makes it a really good fit for rural areas that have a heavily independent libertarian ideological streak amongst, the neighbors, right? Like, you do your thing, I'll do my thing. It's really important that I do my thing. Like, don't impinge on my autonomy. Let me make my own choices, even if you don't agree with them, right? Like, it feels like a thing that would fly here, and yet, there's a lot of resistance to it culturally, which is counterintuitive to me. I wonder if anyone has thoughts about that, because it's really been a phenomenon I've sort of been confused about. Jane?
You just haven't been here long enough.
Ha! That's a thing they say.
You just haven't been here long enough.
Well, what do you think it is?
It's nonsensical though, right? Because we're like, you can't tell me what to do, but I can tell you what to do. If I don't like what you're doing, I don't agree with what you're doing. Yeah, and it is rooted in like the whole Presbyterian puritanical ideology that no one really actually formally subscribes to anymore locally. I mean, you go drive past the church parking lot on a Sunday, there's what, like 6 people there,
Nobody.
but there's
Mhm.
still all quoting stuff, misquoting, whatever. I don't know. I didn't read it, but there is this weird thing about, well, I suppose we ration our compassion is sort of, I shouldn't say our because I don't ration my compassion. I need to, because the cup has emptied. But it is a cultural thing. It's absolutely cultural, and you don't even question it until you start having to confront other issues. Like my whole relationship to harm reduction started 8 years ago, and it came from the mental health side of you can't force the person. I don't want to get too deeply personal, but you can't force a person not to self-harm, but you can do what you can do to minimize the damage. And it really, substance abuse it's just a derivative, it's just another exercise of self-harm that we are allowed to place so much judgment on because we've got laws against the substances that we use, misuse, and abuse. It's sort of, it's really not that different. But it is, because there's no law against cutting your wrists or, cutting your thighs, but there are laws against marijuana and heroin, meth,
Right.
and having it and not having it correctly, and yada, yada, yada. And on one hand, we're like deeply law-abiding citizens. On the other hand, we'll do just about anything to flout the law.
Yeah.
Last week showed a little bit of that here. And I don't know how you term that. I don't know.
I wonder if it's, what do you think, John?
We have four principal ways that we deal with substance use as a culture. We do prevention work, treatment, enforcement, or harm reduction. And we've made a very purposeful series of policy decisions, really for decades now, about which one of those things we're going to provide the most resources to. And it's also the one, probably not coincidentally, that requires the most resources to run, which is enforcement. And we have starved out the other approaches. It's also the reason that every time you go to a meeting at the county level, well, at least every time I do, I get to hear about how the mental health clinic has taken another 5% cut, but the county jail, nope. Not ever, never.
Right.
No?
So we could make different decisions, and we could go. We could look at what the outcomes are of the resources that we're putting in, and I think if we were able to step back and be objective, we might shift some of those resources around.
Right. That's the thing. The sort of sad irony of this is that harm reduction is cheaper than enforcement or treatment, right?
Yeah, but
Everything's cheaper than enforcement. Do you know how much a police
What'd you
officer?
say, Jane? Yeah.
And let's not even talk about paying the pension for 40 years after they work for 20.
Well, I think I'm going to start my lead out. I do want to say that in Delaware County, there is limited access to syringe exchange programming. There are several outreach workers on the ground who provide syringe exchange services, and you kind of have to know who they are. That's how it works here. The CAC has linkages to folks who do that, and I'm happy to provide them. And that's sort of the bargain we've made in this region, where stigma prevents more open celebration of this kind of really effective public health approach to drug use. But it's here. It's not like it's not around. So that's important to know. And then, of course, STAP in Binghamton is offering these services locally too. So locally in Binghamton. But How far do you guys go? Like like if somebody in Delaware County called you up, could they get what they needed from you?
Absolutely. Yep.
There you go.
Yeah, and when we're up in Shenango County, people actually do come from quite a distance.
Mhm.
I'm sure. Yeah. Well, that's really good to know. So then, you're there. People
Yes,
do commute to Bennington.
We'll come out.
That's awesome. You'll meet them where they are. I want to thank you so much, both of you, for joining us, Emily and John, from the Southern Tier AIDS program. I think it's really important to spread the word about how these programs work and are effective. I want to remind y'all that we have a bunch more sessions coming up. I'm doing one at 4 o'clock. I'm going to be moderating it. It's going to be really neat. It's going to be the Central Catskills Chamber of Commerce doing a session on recovery-friendly businesses in partnership with the CAC's staff, SERPA, Dennis Morgan, and some small business owners, and the state expert on tax benefits for businesses that employ people in recovery. And then there's a 5 o'clock session on the science of addiction and overdose, and it's a overdose reversal training. You can get your Narcan training on your computer, and then they will mail you Narcan. Truth Farm is running that. We have other sessions for this week. I am going to post the evaluation links one more time. Please tell us what you think and what we can do better or worse, or next time. I will email folks a copy of this PowerPoint presentation, which has the contact information for these folks if you registered. And I'm very grateful for all of you for your participation. Thank you so much.
Thank you for having me. Thank you.